Most people assume age spots are a surface problem, a cosmetic inconvenience, something to bleach, laser off, and forget. That assumption is costing you, because it is wrong. Age spots are not a skin condition. They are a readout, a compressed, pigmented record of what has been happening inside your liver, your gut, your endocrine system, and your inflammatory pathways, sometimes for years before a single spot appeared. Understanding what that record is actually saying changes everything about how you respond to it. The cell that creates the problem. Let's start at the source, because this is the mechanism everything else connects to. In the deepest living layer of your epidermis, sitting at the dermal-epidermal junction, there are cells called melanocytes. One melanocyte for every 36 structural cells around it. Their job is melanogenesis, synthesizing melanin from the amino acid tyrosine, converting it via tyrosinase into dopaquinone, which oxidizes into the brown-black pigment, responsible for both tanning and hyperpigmentation. Under normal conditions, this process is tightly regulated. UV radiation triggers it. Exposure ends. Melanin production returns to baseline. This is the part no one explains. Age spots form when melanocytes receive a sustained stimulating signal with no corresponding suppression. Not from the sun, but from inside the body. They produce melanin continuously, accumulating it in dense clusters that the overlying skin traps and displays. The question that almost never gets asked in a dermatology appointment: where is that sustained signal actually coming from? Driver 1, the liver. Your liver handles two types of waste: water-soluble compounds excreted through the kidneys and fat-soluble compounds that must be chemically converted before they can leave the body. That conversion, phase 1 oxidation, followed by phase 2 conjugation. Transforms lipophilic toxins, spent hormones, and oxidized lipids into water-soluble metabolites excreted via bile. After 50, phase 2 efficiency declines. Glutathione synthesis drops. UDP, glucuronidyltransferase activity falls. Think of it as a drain that is slowly narrowing. The compounds the liver cannot fully process do not stay there. They get redistributed. The skin, the body's largest organ, and a secondary excretory pathway begins receiving compounds it was never designed to handle at these concentrations. Melanocytes respond to this oxidative load exactly as they respond to UV radiation, by producing more melanin. The spot on your hand is not a sunburn that never faded. It is a localized oxidative event, driven partly from the inside. There is a second component most people have never heard of: lipofuscin. Lipofuscin forms when reactive oxygen species attack fatty acids and cell membranes, and the resulting fragments bond with proteins to create cross-linked pigment aggregates the cell cannot break down or remove. Under a microscope, lipofuscin and age-spot melanin look nearly identical, both yellowish-brown, both clustered, both increasing as the liver's clearance capacity declines. A meaningful portion of what appears on your skin as an age spot is lipofuscin pushed peripherally because the liver can no longer contain it centrally. What this means in practice is this: the liver is a primary upstream driver of visible skin pigmentation. Dandelion root, specifically the dried taproot, contains sesquiterpene lactones, including taraxacin and taraxacerin, which exert a direct choleretic effect, stimulating the liver to increase bile secretion, and the gallbladder to release that bile into the jejunum. Bile is the primary vehicle through which fat-soluble waste leaves the body. 2 cups of dried dandelion root tea daily, 1 heaped teaspoon per cup, steeped 4 minutes in water just below boiling. Provides sufficient concentration to measurably increase bile flow within 10 to 14 days. I have had patients return after 4 weeks, describing the edges of spots they had carried for a decade beginning, in their words, to blur. They were not imagining it. They were describing the early visual consequence of reduced lipofuscin reaching the skin surface. Driver 2, the gut. This is where most people are wrong about skin. They treat the gut and the skin as unrelated systems. They are not. The gut-skin axis operates through 3 parallel mechanisms. First, pro-inflammatory cytokines, interleukin-6 and tumor necrosis factor alpha, are produced in excess during gut dysbiosis and circulate systemically, activating melanocyte receptors the same way melanocyte stimulating hormone does. Second, short-chain fatty acids, butyrate, propionate, acetate, are synthesized by beneficial bacteria fermenting dietary fiber and exert a systemic anti-inflammatory effect throughout the body, including skin tissue. When bacterial populations collapse, that protection disappears. Third, and this is the pathway almost no one considers, the gut microbiome directly controls how much serotonin reaches your skin. Approximately 90% of the body's total serotonin is synthesized in the gut, with production tightly regulated by the local microbial population. Lactobacillus and bifidobacterium species stimulate serotonin production by upregulating tryptophan hydroxylase 1, the rate-limiting enzyme in peripheral serotonin synthesis. In skin tissue, serotonin binds to receptors on melanocyte membranes and exerts a suppressive effect on melanocyte, in production. When lactobacillus populations collapse through antibiotics, chronic stress, or low-fiber diets, the melanocyte break disappears. I treated a woman in her mid-60s who came in for joint inflammation. During her history, she mentioned 2 courses of broad-spectrum amoxicillin clavulanate in the preceding 18 months, one for a urinary tract infection, one post-dental extraction. Both were clinically appropriate. Both are also among the most microbiome disruptive antibiotic regimens in common clinical use. Within 4 months, she had noticed what she described as a sudden proliferation of new spots across her forearms. She assumed it was sun exposure from a trip she had taken, but she had taken similar trips for 20 years without that response. What had changed was not the sun. What had changed was the microbial community governing her melanocyte regulatory signals. We began gut rehabilitation with daily full-fat kefir, traditionally fermented kefir containing between 30 and 60 distinct bacterial and yeast strains, compared to 2 or 3 in commercial yogurt. Within 3 months, the rate of new spot formation had slowed substantially. Not reversed, slowed, in a way that correlated with nothing else we had changed. Driver 3, chronic inflammation. The mechanism connecting systemic inflammation to skin pigmentation runs through your pituitary gland. The compound at the center is pro-opiomelanocortin, POMC. POMC is a large precursor protein that, when cleaved by prohormone convertase enzymes, produces multiple active fragments simultaneously: adrenocorticotropic hormone, beta-endorphin, and, critically, alpha-melanocyte stimulating hormone, alpha-MSH. Alpha-MSH is the most potent direct activator of the melanocortin-1 receptor on melanocyte surfaces. When alpha-MSH binds that receptor, it triggers a transcriptional cascade that drives the expression of tyrosinase and 2 related enzymes. These are the enzymes that perform melanogenesis. Here's the part that changes everything. POMC production in the pituitary is driven by inflammatory cytokines: interleukin-1 beta, interleukin-6, TNF-alpha. When chronic low-grade inflammation keeps cytokine levels persistently elevated, even at levels too low to cause symptoms, the pituitary produces more POMC, which produces more alpha-MSH, which sends melanocytes a continuous activation signal that has nothing to do with how much sun you are getting. The melanocyte does not ask where the signal came from. It responds to the signal available. What this means in practice, invisible, symptomless inflammation is silently instructing your skin to produce more pigment every day. Long-chain omega-3 fatty acids, specifically EPA and DHA, compete with arachidonic acid for incorporation into cell membrane phospholipids, and when incorporated, generate eicosanoid precursors that actively resolve inflammation rather than merely suppressing it. Atlantic herring contains approximately 1.8 grams of EPA and DHA per 100 grams, among the highest concentrations of any widely available fish, higher than most salmon preparations. 2 servings per week for 8 weeks is the minimum duration at which omega-3 intervention produces measurable reductions in IL-6 and TNF-alpha. You are not taking it for your skin directly. You are removing a signaling input that is driving your pituitary to overproduce the hormone that tells melanocytes to activate. Driver 4, vitamin D. This is not what you think. The skin synthesizes vitamin D3 when UVB radiation strikes 7-dehydrocholesterol in the epidermis, producing previtamin D3, which undergoes thermal isomerization to cholecalciferol. This compound is biologically inert. It travels to the liver for first hydroxylation, then to the kidneys for a second hydroxylation, producing calcitriol, the biologically active form. After 50, every step in this chain degrades simultaneously. The concentration of 7-dehydrocholesterol in aging skin falls. Liver enzyme activity declines. Renal conversion efficiency drops. Even people who follow sun exposure guidelines may be producing calcitriol at a fraction of what they produced at 35. In skin tissue, calcitriol binds to vitamin D receptors on melanocyte membranes and directly suppresses melanin production by downregulating tyrosinase transcription through a pathway entirely independent of the inflammatory cascade described above. It also activates Langerhans cells, the immune surveillance layer of the skin, which, when vitamin D sufficient, clear, aberrant, hyperpigmented melanocytes before clusters establish and expand. When calcitriol availability falls, that surveillance degrades. Early hyperpigmented foci that would otherwise have been cleared instead persist, consolidate, and become the spots you see. The standard serum reference range for vitamin D, 20 to 40 nanograms per milliliter, reflects population distribution, not biological optimum. Skin-specific research consistently places the threshold for adequate melanocyte suppression at 40 nanograms per milliliter or higher. At your next appointment, ask your doctor this specific question. Write it down. What was my most recent 25-hydroxyvitamin D level? And is it above 40 nanograms per milliliter? Being reported as normal does not mean it is sufficient for the function being asked of it. Driver 5. The carotenoid layer. The dermal and epidermal layers of your skin contain a depot of carotenoid pigments: beta-carotene, lycopene, lutein, zeaxanthin, absorbed from circulation and concentrated in skin tissue at levels 6 to 12 times higher than serum. Picture it as a thin, invisible filter embedded just beneath the surface of your skin, built entirely from what you eat. These compounds absorb photons directly within the skin, reducing the light reaching melanocyte nuclei. They also quench singlet oxygen and neutralize lipid peroxide radicals before those radicals can initiate the oxidative cascade that upregulates tyrosinase. Press the pads of your first 2 fingers against the inside of your forearm, just above the wrist crease. Hold them there. That layer beneath your fingertips, that faint warmth, that slight give, is where carotenoids accumulate and where they work. That layer is either stocked or depleted based on what you have been eating over the preceding 8 to 12 weeks. Lycopene, found at highest concentration in cooked tomatoes, with tomato paste containing approximately 45 milligrams per 100 grams versus 3 milligrams in raw tomato, has the highest singlet oxygen quenching rate of any dietary carotenoid, approximately double that of beta-carotene. Carotenoids are fat-soluble. Without concurrent dietary fat, absorption from the gut is negligible. This is why the combination that matters is lycopene-rich tomato paste, consumed with full-fat kefir. The fat fraction forms the micellar package carotenoids required to cross the intestinal wall. Topically, the kitchen mask addresses the surface component. 2 tablespoons of cooked tomato paste, 1 teaspoon of cold-pressed rosehip oil, half a teaspoon of raw honey combined in the palm of your hand. Rosehip oil contains trans-retinoic acid, a retinoid that accelerates the natural shedding of the outermost skin layer, where surface-level melanin clusters are densest. Raw honey contributes glucose oxidase, which generates low-level hydrogen peroxide on contact with skin moisture, providing mild keratolytic activity without the irritation of acid peels. Applied for 10 minutes, rinse with cool water twice weekly. What this means in practice, you are simultaneously accelerating the removal of melanin-loaded surface cells and restocking the deep tissue layer that prevents new oxidative damage. Both routes are necessary. Neither works as well without the other. The protocol: find the place where you will do this every morning. Not the ideal place, the place that already exists in your routine, the kitchen counter, the bathroom sink, wherever your day begins. Before anything enters your mouth, drink a full glass of cool water slowly. The drop in gastric temperature triggers a mild vagal reflex that increases bile secretion and gallbladder contraction. This is the mechanical opening of your liver's export pathway. While the water settles, steep 1 heaped teaspoon of dried dandelion root in water at approximately 90 degrees Celsius. Not boiling, which degrades the active compounds, for 4 minutes. Pour 1 cup of full-fat plain kefir, not low-fat, not flavored. Add 1 tablespoon of tomato paste. Stir until uniform. Drink this first. The fat-carotenoid combination reaches the small intestine as an intact micellar package, the form in which carotenoids are absorbed, then the dandelion tea before any solid food. The bitter compounds work most effectively on an empty stomach before food-stimulated digestive activity competes. Twice a week, eat a serving of Atlantic herring, specifically because the EPA to arachidonic acid ratio in Atlantic herring is among the highest in commonly available fish. Every morning, stand at an open window or step outside for 10 to 12 minutes. Not long enough to tan, long enough to deliver UVB photons to the 7-dehydrocholesterol in your forearms and face. Overcast days still transmit 60 to 80% of UVB. Twice a week, in the evening, apply the kitchen mask to the backs of your hands and any affected areas. 10 minutes, cool water rinse. 4 weeks of consistent execution. Bile flow responds within 10 to 14 days. Microbiome shift begins within 3 weeks. Carotenoid depot saturation begins at 8 weeks. The 4-week window is not arbitrary. It is the minimum at which the fastest responding pathways begin producing visible surface changes. The patient who changed. How I explain this, he was 68 years old, a former commercial electrician, 40 years working outdoors, hands that showed every year of it, old burn marks. Chiari creases, and across both dorsal surfaces, large established hyperpigmented lesions he'd been accumulating since his early 50s. He came in for something unrelated. The spots came up almost as an aside. I figured they were His labs told a more specific story. Vitamin D, 26 nanograms per milliliter. Liver enzymes mildly but persistently elevated, consistent with long-term oxidative accumulation, not acute pathology. HHS-CRP at 3.2 milligrams per liter. Technically within normal range, but at the upper boundary, where POMC upregulation becomes clinically significant. No fermented foods in his diet. No fish since childhood. We addressed each driver in sequence, beginning with the gut, because gut-skin axis response is fastest when colonization support is consistent. 4 months later, he came in for a follow-up on the original complaint. Before I asked anything, he held both hands out toward me. The established lesions, which is the likewise, as I says or sale, ones he'd carried for 15 years, were unchanged. That was expected. Melanin clusters embedded in the deep dermis do not clear through nutritional intervention. But the spots that had appeared in the preceding 2 years had lightened visibly at their margins, and in 4 months, 0 new lesions. For someone developing new spots at several per season, 4 months of 0 new formation was not a coincidence. He looked at his hands for a long time before he spoke. I always thought my skin was telling me I was getting old, he said. Now I think it was telling me something was off. That sentence is the entire point of this conversation. What the system is actually saying. 5 drivers, 1 unified mechanism. The liver's phasically prey. Lipofuscin accumulated and redistributed to the skin surface. Gut dysbiosis disrupted the serotonin-mediated brake on melanogenesis. Chronic cytokine elevation drove POMC upregulation and sustained alpha MSH signaling to melanocyte receptors. Declining vitamin D removed the calcitriol-mediated suppression of tyrosinase and degraded immune surveillance of early hyperpigmented cells. Carotenoid depletion removed the photon filtering and radical quenching layer that limits oxidative melanocyte stimulation. None of these require a prescription. None are addressed by topical bleaching. The body does not respond to intent. It responds to consistent biochemical input. Please note that everything shared here is general health and wellness information for educational purposes only. It is not personal medical advice and does not constitute a diagnosis or treatment plan. Before making changes to your diet, supplement protocol, or skincare practice, particularly If you have a diagnosed liver or kidney condition, are taking immunosuppressants or anticoagulants, or are experiencing unexplained skin changes, please consult your physician or a qualified healthcare provider. Unexplained or rapidly changing skin lesions should always be evaluated by a dermatologist before any self-directed intervention.